Hi everyone. Just to quickly round up presentation on diabetes mellitus, I need to make mention of two situations because some people might be confused. Why did he talk so much about diabetes mellitus and I didn't hear anything about emergency situations? Yes, diabetic ketoacidosis or hyperglycemic hyperosmolar state or hyperglycemic nonketotic coma will be addressed just in a bit. Recipients of diabetic ketoacidosis are insulin mixed. In other words, the individual, because diabetic ketoacidosis is common among type 1 diabetic patients. And we've learned that insulin deficiency is a problem because there's a problem with the pancreas. I've gone over the possible causes of the distortion and shutdown of pancreatic function in some other previous presentations, so you can go over them. What else could cause diabetic ketoacidosis besides the fact that the patient has mixed the insulin? So it's not taking the insulin at the appropriate time, it's not taking the injection. So the effect of insulin is lost, and then the level of the glucose is off the road. Ischemia. Ischemia, either mesenteric ischemia, myocardial ischemia, or infarction, mesenteric infarction, myocardial infarction, anything along the system there, along the viscera, could trigger it. Intoxication. People will be cancer and so on, and then some are even being starved. Starvation and alcohol abuse are all going to washing. Infection going on within the system. Actually, when you take white blood cell count in DKA patients, it might be high, not because they have infection, but because of the inflammatory process going on. Illnesses like cholecystitis, pancreatitis, intraoperatively or perioperative stress will all tilt this type 1 patients to diabetic ketoacidosis. What is the pathophysiology here? The low insulin level will increase counter-regulatory hormones function like glucagon, cortisol, growth hormone, and catecholamines. We all have such. And that will push the glucose into the circulatory system beyond necessary. Gluconeogenesis all over. I will be able to handle this in details when we start presentations on emergency medicine. And then I'll be able to give you details as per the fluid replacement, potassium monitoring, glucose monitoring, pH, and the rest. Mortality in DKA is about 5%. Hyperosmolar hyperglycemic states or hyperosmolar non-ketotic coma, the mortality is 50%, and this is happening only in type 2. The precipitants here are drugs, and drugs like diuretics, like thiazides, Thiazides have hyperglycemia as one of the side effects. Cyclosporine, that is immunosuppressant. Glucocorticoids. As a matter of fact, when your patient is on glucocorticoids for a long period of time, please do the individual a favor, check the glucose level. And I've said the other time, urinalysis is not diagnostic. Phenytoin, also stroke, renal failure, congestive cardiac failure. I've made mention of this that when we have this impairment in clearance of metabolites in the system, we are prone to having a lot of troubles. Sepsis, stress that bounds on surgery, dialysis. The presence of low amount of insulin would prevent ketosis, but lower glucose utilization. And then when that happens, the perception will be that there is not enough glucose in the system, and then there will be subsequent upsurge of glucose production by counter-regulatory hormones. I'll be able to talk more on all these two emergency cases that DKA in type 1 could come down with and what to do, and about glycemic hyperstimulatory state in type 2 and the possible interventions that could be done immediately. Details will be in emergency medicine presentations. Thank you for listening to my presentation. Thank you for watching. Please remember to subscribe to my channel so that you can be getting these pieces of info on a timely basis. I appreciate it.